We have run over, but I think it's a great group of people we have here. Why don't I invite all the speakers back up and can have some questions at least. I know there'll be.
One question about endoscopic ablation. Although on your slide there is a left atrial appendage line, I don't know if other speakers are doing it through totally endoscopic, but we can't do it. We do just the box lesion, pulmonary vein, roof inferior line, and left atrial appendage clip, as you showed on your slide. Should we put clip also in that area for the electrophysiologist to come back and to do an extra line, or do you do that line from the left upper pulmonary vein toward the left atrial appendage?
Do you do that line?
Well, if you put your linear pen, which is rather broad on that area coming from the ablation of the enteral ablation of the pulmonary vein, where you include ligament of Marshall inside your ablation, and then the area between your clip and your appendage is a centimeter. It's like you say, it's a very small area. So I just put the linear pen there and ablate on a 3 centimeter long line. I don't make a line like this. I make a long line like this, and then I have done the whole lesion.
So you do an extra one from.
So I go
what
on
he's
top.
suggesting, once you finish, putting a clip there.
But the EPs,
might not be a bad
yeah, but the
idea.
EPs don't have any problem there because you do what they see the clip on the fluoroscopy, and they have the lasso in the left superior pulmonary vein, so they know where they are.
So you put a linear lesion
On
parallel with the base of the clip.
Yeah, absolutely.
I see. So you blade all the way across there.
Because you have your
I think
enteral
that's
lesion with the
probably
bipolar
even
clamp,
better.
and I just put a linear lesion on top of it, so it's a 3 centimeter. So I think there's more chance of having a transmural lesion.
Right. Yeah. Yeah.
Any other questions? I know you were a bit disappointed with the audience, but it's all being recorded, and one of the things we've noticed is there are more than a few thousand hits on the website, so hopefully the long tail, it'll reach more people. But one question I wanted to, one theme that comes out is all if you work very closely with electrophysiologists, and presumably you have to get the electrophysiologists approaching you, because when you approach the electrophysiologist, they see it as a big threat. But is there some sort of, aware that there are some, at the Brompton, certainly Plymouth, that are doing that? Is there any recipe for success, I presume? Just wondered how you get this engagement, because they are so busy. I was with Dr. Cox in Haziger, and he said he didn't need a surgical presence. He said he didn't have a surgeon and didn't miss one. But, you know, it is good to see that. But certainly here, everybody
What Haziger also says is he doesn't have a surgeon who is able to do the procedure.
No, well, he doesn't need one, he told me.
No, I can.
I think the latter part's not correct. I think I've heard him say that if he had a surgeon like some of these guys,
he would
send them. Yeah. But I mentioned to him there are such things as an airplane. You know.
Peter, what do you feel? Sheffield, do you think electrophysiologists? I know Steve Hunter has just moved to your hospital. Has he managed to engage? Or
care of a surge in the need for ablation, and the fact that we've got inordinately huge waits for ablation procedures. It's one way we've taken all the persistence off his off the EP list now, and Steve's slowly working his way through them with his thoracoscopic approach. Yeah. So. And they've I think there was talk earlier about that Sasha was talking about the heart team for what to do with left atrial appendage, and I think the CRM MDT that we have on a weekly basis, we try and get a surgical presence to that increasingly on a regular basis now, and it seems to be helping in terms of the work that's coming our way.
All right. Do you share the disappointment with the NICE guidelines? We're all expecting it to be a bit pro-surgery, but it's a bit
well, again,
surprising.
Steve played some role in the development of those guidelines, and I think what went on in discussion behind closed doors got watered down a little bit in the initial draft, but I think there have been fairly strong representations going back about strengthening that suggestion that certainly first failed catheter ablation goes to surgery, and the non-PAF work comes to surgery earlier.
And certainly the laparoscopic approach appears to be quite an interesting one. Do you worry about the diaphragm at all? Is there an issue with sort of going through the diaphragm, or is it seals on its own, or how does that happen? Do you put a stitch?
At the beginning, we put a stitch on the diaphragm, but then we abandoned it. So there are many reasons for that. So first of all, the liver is really where the incision is, and it's closing the gap. But we found, at least in our initial series, that some patients had the pericardial effusions because of this procedure. So now we are administering the corticosteroids intravenous, and we don't have any problems. But I would see there isn't much audience, as you said, on this session. But believe me, in 10 years from now on, it will be full. Because of what Dr. Cox mentioned, there's a huge potential, and the surgeons didn't realize where the open field is. Everybody is very compact in some other areas which are going to disappear very soon, like aortic surgery, mitral, and so on. But this is an open field with just a few surgeons have touched until now.
And you were saying your bigger market seems to be the US rather than Europe. Is that true?
I think Europe is going to be even bigger because there is much more people which are
suffering.
living in maybe 1.5 times, about 400 million in comparing with 300, 215 in US.
Yeah, most of the numbers that I always show for the U.S. because they're easy to get to, it's about 1.5. All those numbers can be increased by about 1.5 if you're talking about Europe to 1.8. The only I agree with every single thing you just said except for one thing. I think it'll be more than 10 years, and that's based on experience. Yeah. Because I would have sat here 10 years ago. I did probably, and say 10 years from now it's going to be full because we're going to be doing all these cases, and it just is it's very difficult to work this out.
I think one of what I strongly believe, and this is why I'm doing this laparoscopic procedure, is how to get the patients from the doctors which see as even a small incision, whatever you do, really invasive. So you have to persuade them in a way. This is not really a surgery, and this is how we manage to get the patients. So now we don't have any problems. All the persistents are coming to us. They don't question at all. This is, I think, the major goal: how to persuade the cardiologists, the EPs, that these procedures are really minimum invasive.
You know, one of my favorite slides is one that Neve shows occasionally that has on the left a scar on the chest, and on the right a scar on a CT scan of the brain. You know, and he said, which one of these would you rather have? Where would you rather have your scar? But it brings up the point that if some of you guys could get photographs of the inside of the atrium, I mean really good photographs, after multiple catheter ablations, and show that, because I constantly ask EPs, you know, you've done 10,000 of these things, you've never gone up and taken the opportunity to look inside the atrium to see what it looks like, you know, if you're having to do surgery or something. They never look at it. So the invasiveness is strictly all about, I think, what you just said. It's about the size of the scar on the skin. If you look at the amount of invasiveness in the heart, it's way more with catheter ablation than anything you do, because there is such a thing as surgical precision, and you all abide by it. But the heart looks a lot better after surgery than it does after catheter ablation.
But not on the epicardial side.
Not on the epicardial side, maybe not.
I can tell you.
Don't you agree that the most important thing, more than the aggressiveness, because as in the picture that I showed, the size of the scar is not so much of importance, is the results. And that the problem is that even if we have 80 or 90% results success rate, it's almost impossible to get the patients, because I don't know if we are talking the same language, but I've been in cardiology meetings that they show that they have 70% or 60% at 1 year, and if those results are no good, says, yeah, but I have a new catheter, that is going to
Sure.
solve this in the next 6 months, because this is the previous technique, like the previous stent. We are using a new stent, and we will expect new results with this. So I think it's going to be more than 10 years, and I'm sorry, because
I think it is
maybe
too.
it's just the big market that it's behind or something.
Well, you know, I agree 100% with you, Manuel, as I usually do, because I think the best way to treat atrial fib is the way you treat it. It's the way Neve treats it. It's the way Ralph treats it. It's the way I treated it before I retired from clinical practice. I obviously think that's the best. If I had atrial fibrillation that required intervention, that's how I'd want it done, because it works. But it doesn't really matter that much, I think, because the cardiologist will not allow us to put patients on the pump and make a small incision in the chest to fix their atrial fib. I don't think they'll ever do that. I've given up thinking that they're going to do that. That's why I'm saying let's go with the hybrids and see what happens.
Because as you said, the main advantage of the hybrid is to sit down with the cardiologist at the same table.
That's it. There's no advantage in results, and there's no real advantage, I think, in terms of invasiveness, because the pump, what's safer than the pump? I mean, I'd rather be put on the pump and have it done right. But, you know, you're never going to get any patients that way. They're just not going to let you have the patients. And a lot of guys have tried it. And, you know, I guess Neve probably does more standalone than any person in the world. He does maybe, 50 cases a year or something, 60? You know, one a week. And he's been doing it up there, and he's got perfect relationship with his cardiologist. Ralph's been in that place now for 10 years. Same way, he does about 30 a year. 30 or 40 standalones. They do a lot of other stuff, but not standalones.
And I think one of the other problems we have is that the cardiologists, they always join together to make studies together, and they join like 2,000 cases in the same study. And we are only having personal experiences. And I think it's very important. I mean, the first study was up to now. I know there's 2 more other randomized studies going on, but I think we should join more studies and more experience.
How did that work out for you? The fast arrhythmia case.
Oh, well, anything else? I think we're running quite late. There's a drinks reception downstairs, and I'd like to give you all a gift for having come here all the way to Edinburgh. Okay. You have to buy your own Scotch whiskey, but it's a good glass to drink it in. Thank you very much.